Thank you very much. I hope I don't go beyond 45 minutes. 'Cause my respects to Dean Shinji Omoto, Dean Takeo Nakayama, and our distinguished guests from National Taiwan University, the Dean and the Associate Dean, and the Dean of the Faculty of Public Health in Chiang Mai University. Thank you very much for inviting me here to give a short talk about global health. I'm going to talk a little bit about global health in the context of population aging. I am the director of the WHO Kobe Center. So we are a research center based out of the WHO Health Systems Innovation Cluster in headquarters. And we have a vision of innovations for sustainable universal health coverage. We have two main objectives for our research. The first is to carry out research and support gathering evidence to accelerate health systems change in light of population aging. The distinguished dean mentioned this morning pressures on human resources, pressures on health systems in response to changes in our environment. And this is the kind of research that's critical now so that we can work towards building health systems of the future to respond to these types of changes. Our second objective is to stimulate social, technological, and systems innovations. We believe that innovations are crucial to accelerate progress, to accelerate access to basic health services, particularly in low and middle income countries, as well as to respond to resource constraints. I will talk a little bit today about why population aging is an important issue for the world and also Asia. I'll discuss healthcare as a human right, particularly in light of the international commitments under the Sustainable Development Goals. And I'll talk a little bit about the research agenda in moving forward the progressive realization of universal health coverage, particularly in light of the pressures of population aging. This is simply a graph that shows the changes in population growth from 1950 to 2050, and the colors are by the WHO regions. So we can see an increase in population, but a reduction in the acceleration of population growth, and that we are projected to have between 9 and 10 million people by 2050. And you can see that this growth is driven primarily by changes in the African region as well as the Southeast Asian region. These kinds of broad population growth hide some of the changes in population by age groups. This is a graph from the UNDESA, our UN agency responsible for population. And they are highlighting the issue of population aging and the increase in the share of the people over 60 years of age. So by 2050, we will see that 1 in 5 people will be over the age of 60 years. And from the graph, you can see that the largest share is in yellow, is in Asia, as represented by the yellow region. So population aging is a particularly important issue for the Asia region. The UNDESA also reports that 80% of older people will be living in low and middle income countries. So this means that population aging is not just a problem for Japan, not just a problem for wealthy countries in Europe, but it's going to be a very important challenge for all countries, regardless of their level of economic development. We see that this change is happening very quickly. This is a graph from our headquarters experts on health information systems, and we're seeing that on average, between 2000 and 2015, we've had gains in life expectancy across the world of about 5 years. So this is a very rapid change, a very rapid increase in life expectancy. In the two regions, the CR region is Southeast Asia region, and the WIPRO region is Western Pacific region. Japan is in the Western Pacific region. So we can see that these changes globally are driven very much by achievements in the control of communicable diseases, HIV, TB, and malaria in particular, as well as strengthening our response to maternal and child health problems. Well, we can also see, for example, in the Western Pacific region, there have been great progress towards non-communicable disease control or the prevention of diabetes, hypertension, cardiovascular diseases. This simply shows the absolute numbers of population 60 years or older, and the share as a share of the total population. And the countries here are Japan and the ASEAN region. So we can see, for example, that most of these countries will see by 2015 approximately between 15 and 45% of the population will be over 60 years of age. And in some cases, they represent very large numbers. In Indonesia, we'll see it's estimated that 60 million people will be over 60 years of age. But even in smaller countries like Cambodia, Laos, they will have fewer numbers, but they will comprise 15% or more of the population. So there will be a large share of the people who are demanding health services in these countries. One of the major reasons behind this population aging is fertility. We are seeing a rapid decline in fertility. And many countries, over 40 countries are now at replacement level, below two children per woman. So we're seeing rapid declines in fertility in all regions, with the exception of the African region and in parts of the EMRA region, the Eastern Mediterranean region. So this is one of the most important driving factors, and it really does reflect the success in ensuring access to family planning services and basic healthcare services. Because of these population changes, we are seeing changes also in the burden of disease. This is a ranking of DALYs, disability adjusted life years, between 1990 and 2016. And we're seeing, for example, in 1990, the first cause of DALYs was diarrheal diseases. And this has changed in 2016 to cardiovascular diseases. And so we are seeing an increasing number of non-communicable diseases. And now WHO estimates that non-communicable diseases, which we consider cardiovascular diseases, diabetes, chronic obstructive pulmonary diseases, they account for 68% of total deaths globally, or 38 million deaths per year. I'm going to talk a little bit now about the United Nations Sustainable Development Goals. I'm not sure if you're familiar with this, but this is really the platform for global health. The Sustainable Development Goals followed the Millennium Development Goals that ended in 2015, that were focused very much on the communicable disease burden, HIV, TB, and malaria in particular. And we did see rapid progress in these areas between 2000 and 2015. When UN member states came to the table again in 2015, they decided that they wanted to have an agenda for sustainable development that was relevant to all countries, not just poor countries. And so they've put forward a very ambitious agenda for sustainable development and a set of goals that aims to be relevant to all countries and aims to challenge all countries to strive to improve development. There is one health goal and 13 targets for health under the Sustainable Development Goals. We see targets related to non-communicable diseases, including reducing premature mortality or death before the age of 60 from non-communicable diseases, strengthening our response to the harmful use of alcohol, strengthening the implementation of tobacco control measures, as well as promoting access through achieving universal health coverage, which we define as access to basic services for the whole population, and extending access to medicines, essential medicines and vaccines. I will focus on SDG Goal 3, which is ensuring healthy lives and promoting well-being for the whole population. So this target is about what we call universal health coverage. So, so very basically, universal health coverage is to ensure that every person has access to the health services that they need without suffering a financial hardship or without going into poverty because of seeking these services. So this is a very ambitious goal, and it has a certain number of implications for our planning. The UHC is built on a number of pillars. There are political pillars, ethical pillars, technical pillars, and economic pillars. So this is the justification for UHC. And if we look back in our history, we see that the concept of health as a human right is really, it's not a new concept. It's something that UN member states have committed to since 1948, since the Universal Declaration of Human Rights, when all UN member states committed to the right to each individual of housing and medical care and necessary social services. It was also reiterated in the International Covenant on Economic, Cultural, and Social Rights. And because of these commitments, very early commitments, we see that many countries around the world have already made national commitments within their own constitutions to the right to health. If we think about the ethical pillar of UHC implies that the kind of health system that we build reflects the values that we wish to promote within our health system. So if we commit to UHC, if we commit to health as a human right, we are committing to the values of equity, to the values of fairness, to the values of social solidarity. I think in Japan they call it human solidarity. We are also saying that healthcare is not just a commodity, it's not just a perk, it's not a right because you have a job or a privilege, but it's a social right for all individuals. There's a technical pillar for UHC. So the basis of UHC is what we call progressive realization. So the idea is that no matter what your starting point in terms of your health system, we strive to do better. There are always better things that we can do. As you were mentioning earlier in the opening statement, even in Japan, a very wealthy, very strong health system, there are areas where we can promote quality, where we can promote value, where we can achieve better health. There are waste and inefficiencies in every health system. And there are innovations that we can use to achieve better impact. There is a strong economic justification for UHC. In 2015, there was an economist declaration of UHC. It was put forward by Larry Summers in the US that established that UHC is not just about the right thing to do or the proper thing to do, but it's an economically smart thing to do. Because health is a means to eradicate poverty and to promote economic growth. So this really sets the stage. We typically measure economic growth by GDP, or rate of GDP growth. But are we looking at the very driver of economic growth, which is human capital? It's individuals and individual contribution to an economy. We also have very substantial evidence that well-designed reforms, healthcare reforms to achieve universal coverage can have wide-ranging impacts. They can reduce the growth in healthcare costs and prices by increasing efficiency and quality. You can establish greater financial security among households if they know that they will not fall into poverty by seeking healthcare. And you can, in the US, for example, they've shown that it can support the labor market. So where insurance is not necessarily linked to your job, then you're not afraid of changing jobs. You're not afraid of looking for new employment and further growing the economy as such. When we talk about healthcare as a human right, we have very concrete implications for the design of universal health coverage. we need to, when we design universal health coverage, we need to design it in such a way that you reflect the values of equity, fairness, and social or human solidarity. We know that there is no single model of UHC, so universality does not imply uniformity. There's no one way to implement UHC, and each country has a different institutional starting point. And we know that no country has fully achieved UHC, but that it is a process of progressive realization. So it's relevant to all countries. And we see, for example, healthcare systems across the world, regardless of income levels or regardless of economic development, face remarkably similar challenges. Most are struggling with rapidly increasing healthcare costs. Populations need to be protected from catastrophic healthcare payments or from falling into poverty. We see wide variations in technical quality within countries as well as across countries. We also know that with universal health coverage, we need to be more responsive to people's needs or expectations. But as we build our health system, people's expectations also increase. Their demands also increase. So we continually struggle with responding to people's demands and expectations. We also see lack of access to cost-effective care across all different countries in the world, and this could be related to poverty, this could be related to a lack of insurance coverage, this could be a geographical challenge, differences between rural or remote areas, or individual discrimination, or even lack of incentives for the provision of essential cost-effective procedures. This has been shown widely in the US, for example, where you have low incentives for people to deliver cost-effective care. They don't do it. They go for different types of care or care in which can get higher reimbursement. So I'm going to talk about three very practical questions about moving towards sustainable, progressive, universal health coverage. There are many questions that countries face, but three questions are about sufficient resources. Will we have enough money to deliver good quality health care for the whole population? Are our service delivery models appropriate? Most countries have hospital-based service delivery models. Will these enable us to reach the whole population? And what kinds of innovations do we need to accelerate progress? And across all of these questions are how population aging affects these kind of responses. When we talk about money in WHO, we always show this cube. I don't know if anybody's seen it before, but this is our WHO cube, where we try to define the main questions that we need to respond to in terms of universal health coverage and the policies related to the implementation of coverage. We have three questions. The first is the breadth. You have to define who is insured or who is covered through your universal health package. The depth, or what kind of services do you cover, and the height. How much of this cost of the benefits package is covered by public funding? So these are the three main questions that we grapple with. When you talk about healthcare as a human right, it does imply that we have committed to systems in place that cover the entire population. So the breadth is universal. It also implies that some people will not be able to pay. We know that in every country you have populations that are simply unable to contribute, and so this requires public funding for those populations, or mechanisms to fund coverage for people who are unable to contribute. A very important challenge that we see is healthcare spending. When we look, for example, at covering the whole population, countries frequently are concerned that particularly older populations are going to be too expensive, that we're going to see a rapid acceleration of healthcare costs as population age. And indeed, this is three countries from the OECD health statistics, the Czech Republic, Korea, and the Netherlands, where we see uniformly an increase in healthcare spending by age group, and this is adjusted to per capita spending. And what we see, however, is not a uniform increase in spending at the same level, but a wide variation across countries. So when we think about this variation, what is really behind these numbers? One of the most important issues behind these numbers is the service delivery model. How much money you spend depends very much on how you allocate resources across the health system. So this is an example of spending on dementia, again from OECD. It's 3 slightly different countries, Korea, Germany, and the Netherlands. And what we can see is that they allocate money across the health system in a very different way. And this is really, if we think about our total spending, we have to try to look underneath the numbers to see how we allocate these resources across our health system to achieve the most value, to achieve the most health care for our spending dollars. And when we start to think about these kind of questions, when we look at population aging, what we see is that these increases in spending may simply be exacerbating the service, how we've designed our health services. And so this implies that when we look at addressing the problems of population aging, we need to rapidly address the key drivers of cost escalation and quality globally. This is a reliance on hospital-based care. We know that if you deliver routine care services in a hospital, it's more costly and inefficient compared with primary care services. And in fact, patients prefer generally primary care services that are closer to their own communities. Systems that are based on fee-for-service payments to healthcare providers. How we pay healthcare providers is critical to efficiency and quality. We know that most countries in the world rely on fee-for-service payments to healthcare providers, so you're paying based on the number of services rather than the outcomes, rather than quality of life. And we've seen a remarkable change both in the kinds of services that are delivered and the quality of those services when we start to pay healthcare providers for the outcomes they achieve and pay healthcare providers for keeping people healthy versus utilization within the health services. We also know that one of the most important drivers of cost escalation is the introduction of new technologies, medicine, and diagnostics without sufficient knowledge about whether they're better than what is currently being used. So we see this, for example, in the US, my own country, where you introduce diagnostics without a complete evaluation of whether or not that extra dollar, or that extra amount of money that you pay for these diagnostics give you better patient outcomes. Going back to the service delivery model, this is the WHO PHC service delivery model, which focuses on primary health care and what we call the patient-centered approach. So with population aging comes a stronger emphasis on different outcomes. When we talk about, for example, our achievements in the health sector, we tend to talk about mortality, we tend to talk about curing a disease. But when you have older populations, it's more about ensuring autonomy, ensuring functional ability, and it's not necessarily, it's about a continuous care model. So I think this implies that we have to think about the design of our system so that we can continually monitor patients, put systems in place where we can identify problems quickly so that we can refer patients who do have serious needs. So I think this kind of a primary care model is well adapted to the needs of, particularly the needs of older populations. In addition, during the last years of life, we see that health needs are also interlinked with social needs. So we're seeing some very interesting innovations where primary healthcare providers are not just prescribing medicine, but they're prescribing social interaction. They're prescribing community activities. They're prescribing walking. They're prescribing all sorts of different kinds of activities to ensure that people are healthy, are active, they are not socially isolated in their communities. And this kind of model enables you to pull in social services that are so critical for the welfare of older populations. Lastly, I'm going to talk a little bit about the innovations that we need to accelerate universal health coverage. This is a new area of work that we're doing at Kobe, and so I would be very keen to hear about your views on this one. This is a graph. When we think about innovations, WHO is challenged, particularly the Kobe Center, when we are thinking about innovations, particularly to accelerate UHC and addressing population aging. We are challenged by WHO to focus very much on the low and middle income countries that are facing some of the most serious health challenges. So when we look at the challenges, this is a graph of most WHO member states, about 190 WHO member states for which we have data on healthy life expectancy. And so the blue bar is healthy life expectancy, and the red dot is an index of universal health coverage. So this is basically an index of how well the health system is functioning in the given country. So when we look at this, so the idea here is that we're looking at what kind of innovations are important to these countries. And so what we see very generally, I will categorize countries in different groupings. And the groupings are based very much on the kinds of health problems that you see in these countries. What are the challenges to achieving longer life expectancy? What are the health system's challenges, and what innovations can be used to address these challenges? So if we look at this grouping of countries at the very end, we see that we have 59 countries, in fact, in which healthy life expectancy is under 60 years of age. And we also see, by the red dots, huge variations in attainment of universal health coverage or attainment, the strength of the health system. These countries, for the most part, are struggling with some of the most fundamental challenges of promoting life expectancy, child mortality, fertility, and access to basic services. We can see, for example, relatively low access to family planning. I think this figure is 2015, 41% access to family planning in the sub-Saharan African region, in which most of these countries fall, relatively low access to antenatal care and skilled attendance at birth, and even some very fundamental public health functions such as immunization as measured by DPT-3. So in this environment, the kind of innovations that are needed and the kind of innovations that we see most often are those innovations to extend access to basic healthcare services. There is something called frugal innovations. So these are have been defined in one instance as lean tools and techniques. You can't see this picture. This is a very cool picture of an ECG machine that's being used in India. So it's an ECG machine that's been developed for environments in which you cannot rely on electricity. It's durable, it's portable, it's adapted to printer technology. So this is a very good example of a technology that's being used in a resource-constrained environment. It's also an excellent example of a technology that's designed for use in India, but it's now being adopted in Europe and other countries in the world. So it's what we call reverse innovation. So it's a very good, durable, portable technology that now has applications globally. Another example of a frugal innovation is an opportunistic solution. So this is an example of applying technology that was not designed for the health sector, but has important applications for health problems. So we see, for example, a very common program of using SMS to promote medication adherence. So this is using simple technology, and it's having very important impact on adherence to medication for, in this instance, HIV care and treatment. If we look at this middle set of countries, we see quite a huge variation. Healthy life expectancy between 60 and 70 years, and still a wide variation in levels of UHC attainment. But what we see, some of the biggest challenges to promote healthy life expectancy for these countries is about prevention and control of non-communicable diseases. So, for example, we have some of the Pacific Islands here. We have countries in South America, Latin America. What we see in these countries, they're investing in their health systems, but they have not yet extended full access to the most cost-effective interventions that promote healthy aging. For example, prevention and control of diabetes and hypertension. So this is one of the main challenges that we're seeing. It's quite a broad generalization, but it's a main challenge that we're seeing in many of these countries to promote healthy life expectancy. The health system in this set of countries are struggling with service quality and efficiencies. And we see amazing innovations actually in some of these countries to promote service quality and efficiencies. We see a lot of organizational innovation in which countries are moving away from hospital-based systems to patient-centered systems. We see, for example, you mentioned human resources. This morning, I was working in South Africa previously, and they promoted a very interesting innovation in terms of task shifting. So nurses were prescribing drugs, basically at the primary center level. And this is an innovation, a very important innovation, but it's an innovation that came out of a resource-constrained environment simply because they could not deploy doctors to these regions. So these types of innovations are very interesting because they're coming out of the pressure of resource constraints. We're also seeing lots of innovation in terms of how we pay for prevention, how we pay for quality, how we pay for health outcomes. The technological innovations to improve service quality and efficiency are wide-ranging. So we do see that these technologies, such as electronic medical records that are widely used in more developed settings, are being adopted, even though they're rather expensive. We are seeing telemedicine. And we're also seeing, again, technologies to improve medication adherence, apps, reminder systems, SMS, smart pills, cash incentive, coaching systems. So we're seeing a whole series of innovations that enable us to get better health for every single amount of resource that we put into the health system. The last set of countries include Japan and Italy, Europe, where we have healthy life expectancy in excess of 70 years and relatively high levels of UHC attainment. In these countries, what we are seeing, for example, are growing populations of 85 plus, though we're seeing rapid aging, and the aging is taking place among the oldest group of people. We're also seeing very high consumer expectations from the health system. People are making a lot of demands on the health system. And these countries are, while they have achieved universal health coverage to a large extent, they're facing the issue of cost control in trying to keep costs contained. The innovations that we're seeing in these kinds of settings, we're also seeing delivery models, but we're seeing delivery models that are addressing the needs of older people. Particularly service delivery models that deal with what we call high-cost, high-need patients, people that have multiple chronic conditions, require heavy use of the health system. We're seeing very important innovations in terms of the integration of social care into the healthcare system, because we're realizing that things like social isolation are as dangerous for people as smoking. We're also seeing innovations in terms of end-of-life care. How do we manage individuals and the needs of individuals at the end of their life? There is a proliferation of technologies in these countries, particularly Japan. We're seeing lots of different types of technologies, but I would say that many technological innovations that exist, many provide information to individuals and families. They empower patients, they empower their families, they give them information so that individuals can play a much more important role in their own health care, in monitoring their own health status. Their families and their communities can be a part of identifying when there's risk, identifying when there's a problems, making sure that they access care when there are serious problems. So we have wearable technologies, we have innovations in patient remote monitoring systems, and here's an example of a blood pressure e-reader. So finally, I've come to the strategic directions for research. And so this is the huge agenda, as you can imagine, but I've tried to identify a few issues that I think are really important, and it's something that we at COBE are trying to work on. So the first issue is about the implications of population aging on sustainable financing and financial protection of older adults. Currently most countries don't actually collect data about how much they spend, for example, in long-term care systems. And so it's actually very difficult to even identify how population aging is affecting expenditure growth. We do see that the financial protection for older adults is critical, particularly for older adults that have to continuously return to the health system. In health systems where you have a co-payment, it's fine for someone who has to seek care once or twice a year, but where you have continuous care and you have to continually go back, the co-payments can be impoverishing. We need to generate more evidence on service delivery configurations. As we mentioned, underlying how much we spend on healthcare is how we deliver healthcare, how we allocate resources across our health systems. And what are the service delivery configurations, particularly for older populations, that not only reduce mortality but promote quality of life? And lastly, it's critical to identify and research those innovations that can extend the reach of the health system, particularly in low-income populations, promote systems change, and empower individuals, empower communities and their families to be a part of their own treatment and care priorities. Thank you very much.